Hi everyone, myself Dr. Rohith, Associate Professor in the Department of Pediatrics, VJS Global Institute of Medical Sciences. I would like to discuss regarding febrile seizures today and some MCQs regarding the febrile seizures. If you come to the definition of febrile seizure, very important is the age group that occur between the ages of 6 and 60 months. Most probably it peaks between 12 to 18 months, peaking at around 12 to 18 months. The second important factor is the temperature of 38 degrees Celsius or more. Third important factor is not the result of CNS infection or any metabolic disturbance. And very fourth important is in the absence of history of prior afebrile seizure. These are the four components should be there to call it as a febrile seizure. It is a commonly used definition for febrile seizure. But in International League Against Epilepsy, they suggest seizure occurring in childhood after 1 month of age associated with febrile illness that is not caused by an infection of the central nervous system. Therefore, in International League Against Epilepsy, they define the febrile seizure from the age of 1 month, whereas routinely we classify the febrile seizure between the ages of 6 to 60 months. If you come to the classification of febrile seizure, we have two types of classification. One is simple febrile seizure, another one is complex febrile seizure. To call it a simple febrile seizure, it should be one per febrile episode or one febrile episode, one seizure should be there, and that seizure should be last less than 15 minutes, and it should be of generalized tonic-clonic seizures, and it should not recur in 24-hour period, and the post-ictal days should be very short. It should be very short. These are the characteristic feature of simple febrile seizure. To call it a simple febrile seizure, all the components should be there. Whereas if you come to the complex febrile seizures, it is more than one per febrile episodes and it lasts for more than 15 minutes. Either it may be a focal or generalized with prolonged in nature, and it recurs within a 24-hour period, and very commonly it is associated with post-ictal some drowsiness or some weakness that is called torch spasm. That is this is very important, that is classification of febrile seizure into whether it is simple and the complex. We have so many other terminologies we use in relation to the febrile seizure. Febrile status epilepticus. If the baby was brought with the seizure lasting for more than 30 minutes, then we call it as a febrile status epilepticus. What do you mean by febrile seizure plus? Where normally we define febrile seizure between the ages of 6 months to 6 years. If it is extend beyond 6 years with no other involvement, only the fever is the cause, then we call it as a febrile seizure plus. If you come to the febrile infection related epilepsy, that is PIRS, where there will be an infection in relation to the epilepsy, that is called febrile infection related epilepsy. If you come to generalized epilepsy with febrile seizure plus, where they'll have a family history of febrile seizure. It may be a simple febrile seizure, or it may be a complex febrile seizure, or it may be a febrile seizure, which is lasting behind 6 years. Those terminologies will be called as a generalized epilepsy with febrile seizure. Plus, the very one more entity is symptomatic febrile seizure. What do I mean by symptomatic febrile seizure means? Where the child will have some neurodevelopmental delay. If there is a neurodevelopmental delay, the only associated feature with convulsions or fever, then we call it as a symptomatic febrile seizure. These terminologies are very important in order to label the patients. Very important in febrile seizure is the risk factors for recurrence, because febrile seizure is known for recurrence. Okay, there are mainly we divide the risk factors into major risk factors and the minor risk factors. The major risk factor is the one where if the age is less than 1 year, if the duration of fever is less than 24 hours, if the fever is 38 to 39 degrees Celsius, this is a major risk factor. The minor risk factors are family history of febrile seizure or epilepsy, complex febrile seizure, male gender, low serum sodium at the time of presentation, and if there is a daycare. These are the minor. Therefore, if you take the risk factors, if there are no risk factors, the chance of recurrence is only 12%. If there is a one risk factor, the chance of recurrence will be 30 to 50%. If there is a two risk factors, the chance of getting will be 50 to 70%. And three or more risk factors is there. Definitely it is 73 to 100%. Therefore, the febrile seizure is known for recurrence. Therefore, risk of recurrence, if you define in terms of first episode, it is 30%. After second episode, it is 50%. If the onset of febrile seizure, if it is less than 1 year of age, the chance will be around 50%. Therefore, overall, the risk of recurrence in a case of febrile seizure will be around 30 to 50%. And that is the known for recurrence. Then in the future epilepsy, from this febrile seizure, the chances of getting the epilepsy will be with simple febrile seizure, it is 1%. If it is recurrent febrile seizure, it is 4%. If it is a complex febrile seizure, in that if it is lasting for more than 15 minutes, or if it is a recurrent seizure, then it is 6%. That is very, very important. Complex febrile seizure which is lasting for more than 15 minutes or recurrent in nature will be 6%. Fever less than 1 hour before febrile seizure. Fever less than 1 hour before febrile seizure will be 11%. If they have a family history of epilepsy, 18%. If there is a complex febrile seizure of focal in origin, then it will be 29%. If there is a neurodevelopmental abnormality, the chances will be very high. One of the risk factors for future epilepsy, with the highest rate will be the neurodevelopmental abnormality. Then the next one is the complex febrile seizure with focal in origin. When compared to complex febrile seizure, which is prolonged in nature or recurrent in nature. Because if you come to the etiopathogenesis for this febrile seizure, what may be the cause for the fever? The most commonest cause they are suspecting is infectious. In the infectious, what viruses they are suspecting, especially what infection they are suspecting is upper respiratory tract infection, the most commonest cause. Upper respiratory tract infection is the most commonest cause for the febrile seizure. In the upper respiratory tract infection, it is influenza virus, para-influenza virus, adenovirus will be the most common cause. And the roseola infantum is also one of the important cause for the febrile seizure. There is HHV6B R7, which is the most common cause for the recurrent febrile seizure in a case of a infectious etiology. If you come to the immunization, the DPT and MMR with varicella, they are the high chances of getting the febrile seizure. And they propose one more theory where iron deficiency may be precipitate the febrile seizure, but controversy still exists whether the iron deficiency will lead to febrile seizure or not. Will not be that much updated. And they play an important role in the genetics where sodium channel blockers have some deficiency, and also febrile genes are there. One gene, 2 gene, 3 gene, 4 gene, and there's one more cascade where there will be a differences between the pro-inflammatory and anti-inflammatory mediators. That may also will lead to some sort of recurrent febrile seizures. And very important in relation to that one is interleukin R1A and interleukin 8. They play an important role. Those inflammatory mediators, which one will lead to the temporal sclerosis, hippocampal sclerosis. This hippocampal sclerosis is the one which lead to temporal lobe epilepsy. If they are recurrent febrile seizure, you have to keep in mind there may be having some genetic factors. And one more Mayer's hypothesis says that if there is a febrile seizure, the repeated febrile seizure, it will reduce the blood supply to the temporal lobe. Because of that one, they'll go for sclerosis, and there will be permanent temporal lobe sclerosis will be seen, and therefore they are more prone for getting temporal lobe epilepsy. Therefore, febrile seizure may lead to the temporal lobe epilepsies. Now, how to evaluate a case of a febrile seizure? The first thing is, if the child is actively convulsing, you have to stabilize the patient. That is A, B, C, D. That is A for airway, B for breathing, C for circulation, D you have to go with the drugs, and E means you have to evaluate if the child is actively convulsing. If the child brought with a history of convulsion with fever, and now child is very stable, you have to elicit the history. Whether when they got the fever, within 1 hour of fever, the baby got the convulsion, or after 24 hours of the fever, the baby got the convulsion. History is very, very important, and you have to examine for the child any neurological deficit is there. any neurodevelopmental delay will be there, because those things are very important. And in the managing the acute problem, that is, if the child is having some other issues, you have to manage those issues. And what investigations is needed, whether these child need any investigations, you have to think depending upon the type of the febrile seizures. And very important concept in case of febrile seizure is counseling. The parental counseling is very important, and in that counseling you have to explain the benign nature of the disease, and also the recurrence and the future epilepsy risk factors for the parent. That is very important, because the parents are very anxious regarding the convulsions. Very important aspect in febrile seizure is counseling regarding the benign nature of the condition and the known risk factors, where the chances of getting recurrence and the future epilepsy you have to monitor. You have to explain to the parent. That is the main important part in the management of the febrile seizure. If you come to the investigations in case of febrile seizure, the blood test routinely, the blood test is not required if there is a simple febrile seizure. Only the blood test is required if there is a complex febrile seizure, or if the child is brought with the febrile status epilepticus, or if the child is having some neurological features, some infectious features, then only the routine blood test like complete blood count, serum electrolytes, or serum calcium, serum alkaline phosphatase, serum phosphorus, and blood sugar, all those things are needed. Only if there is a complex febrile seizure, or if there is a febrile status epilepticus. Then if you come to the lumbar puncture, if it is a case of simple febrile seizure, we don't do lumbar puncture. But if the age is less than 6 months, then it is indicated. Or if the age is between 6 to 12 months, with there is a prior antibiotic therapy is there, or if they have not taken the vaccination, especially EBA and pneumococcal vaccination, or if there is clinically there is a strong suspicion of your meningitis, then you need to do a lumbar puncture. If it is more than 12 months, you have to decide based on the clinical features. If you come to the EEG, routinely EEG is not recommended in a case of a simple febrile seizure. EEG doesn't predict the future recurrence of febrile seizure, and also it won't predict the future epilepsies. Only the EEG is recommended mainly if the child is brought with a febrile status epilepticus, or if there is a recurrent febrile seizures, or if there is a focal complex febrile seizure, then we require the EEG. If you come to the MRI, MRI is also not routinely required for the simple febrile seizure. Only if it is a complex febrile seizure with focal in origin, or if there is a febrile status epilepticus, or if you are suspecting a neurodevelopmental delay, then the MRI is indicated. Therefore, we have to decide depending upon the what type of seizure and what type of febrile seizure, whether it is simple, complex, or febrile status epilepticus, or generalized epilepsy with febrile seizure plus. Depending upon that, we have to go with the investigations. Genetic testing, if you're strongly suspecting the epilepsy syndromes in the form of Dravet, which is a severe bad prognosis, after the counseling with the parents only, if you're strongly suspecting, you have to go for a genetic testing, especially if they have a different semiologies in relation to the seizure activities. That is in the form of myoclonic seizure, clonic seizure, tonic seizure, or afebrile seizures in those periods. If you come to the management aspect, what you can do best in the hospital, what you can do, how you can counsel the parents, and also very important how to manage at home. If you come to the management at home, simple, you can advise antipyretics for first 48 hours with every 6 hourly of paracetamol, 15 mg per kg per dose. And anticonvulsants, we have two types of anticonvulsants we can use at home. One is intranasal midazolam, rectal diazepam, and we have a buccal lorazepam also. In that, very best is intranasal midazolam. That is a midazolam spray, where it's available 0.5 mg per spray. In that, we give 0.2 mg per kg, 0.2 mg per kg. Maximum we can give a 5 mg of midazolam. That is a home management. When to give midazolam spray means if the seizure is lasting for more than 3 minutes at home, or 3 to 5 minutes at home, you can give. And when to repeat, if the seizure persistingly lasting once again after 5 minutes, 5 to 10 minutes, you can repeat the second dose of intranasal midazolam. That is the most preferred anticonvulsant at home. And very important aspect in the management of febrile seizure is counseling the parents regarding its benign nature, are recurrent in nature, and the future epilepsies and management at home. That is very, very important. What best you can do in a hospital means acute management in the form of airway, breathing, circulation, and if it is a febrile status epilepticus, you have to follow the epilepsy protocol. And if it is simple febrile seizure and it is settled, only you have to observe for another 24 hours whether the recurrence in or not. Okay, and you have to give antipyretics once again for 24 to 48 hours. Then considering the prophylaxis, whether to go with intermittent prophylaxis or a continuous prophylaxis. Intermittent prophylaxis means giving the anticonvulsant only for 3 days during the febrile episodes. This indicated mainly if there is a recurrent simple febrile seizures, recurrent, or if the parental anxiety is there, or if they are very away from the medical facilities, then you can go for an intermittent anticonvulsant prophylaxis. That best drug is clobazam. You can use from 0.5 to 1 mg per kg per day. You can use TID or a BD. TID or a twice a day or a thrice a day. You can use the clobazam tablet if the intermittent prophylaxis agent. Only for first 3 days is sufficient. Even though fever lasts for 10 days or 15 days, the first 3 days of clobazam is sufficient to manage, to control the febrile seizure. But as such, antipyretics will not prevent the future recurrence of febrile seizure. If you come to the continuous prophylaxis, when to consider continuous prophylaxis means, suppose if the child is brought with febrile status epilepticus, or if the child is having a febrile seizure with a neurodevelopmental delay, or if it is a recurrent complex febrile seizures, then we are advising a continuous prophylaxis. Here, the drug of choice is always valproate and phenobarbital. You should never use phenytoin. You should never use phenytoin because phenytoin is a sodium channel block. If you come to the intermittent versus continuous prophylaxis, when to consider intermittent, when to consider continuous. If it is the intermittent, we prefer clobazam. When to go with the clobazam means if there is a recurrent simple febrile seizure, or if the parental anxiety is there, or if they are very away from the medical facility, then you can go for a intermittent febrile seizure prophylaxis with using clobazam point 0.5 to 0.7 or 1 mg per kg per day, twice or thrice a day. You can use for first 3 days is sufficient. Whereas in continuous prophylaxis, we prefer valproate or phenobarbital. Continuous prophylaxis is considered if there is a febrile status epilepticus, or if there is a neurodevelopmental delay with febrile status epilepticus or complex febrile seizure. We prefer a continuous febrile seizure prophylaxis where we are giving valproate for 2 years. We have to use for 2 years or phenobarbital, but phenytoin is contraindicated in febrile seizure prophylaxis. Okay, because it is a sodium channel blocker, it's going to exaggerate the Dravet syndrome, one of the severe form of febrile seizure, one of the severe form of the febrile seizure where it continues behind the 2 years of age. Okay, therefore that is the prophylaxis in relation to the febrile seizure. With this brief explanation on febrile seizure, we would like to discuss some of the MCQs. If you come to the first MCQ, what is true regarding febrile seizure? The first is postictal unconsciousness, long-term phenytoin requirement, interictal EEG normal, status epilepsy is common. You see, postictal unconsciousness will be very less. I told you simple febrile seizure, there is no postictal unconsciousness, and even with complex febrile seizure, it is very less. And the long-term phenytoin doesn't require, and interictal EEG will be always normal if there is febrile seizure. And the status epilepsy is quite less with regard to the febrile seizure. If you go to the second question, what is the commonest cause of convulsion in a child with a fever? It is always, it is not meningitis, it is not epilepsy, it is not hypothyroidism, it is febrile convulsion. One of the commonest encountered condition in pediatric population is with convulsion is febrile convulsion. If a 4-year-old male child has febrile seizure, best prophylaxis is paracetamol. Is only, it is not going to prevent your convulsions. Paracetamol and diazepam will not be. Only diazepam is known to prevent the. It acts as a best prophylaxis, especially the intermittent prophylaxis. in case of a febrile seizure. That is, diazepam is one of the important intermittent prophylaxis. Especially, we use clobazam, and for short acting, we use either midazolam or lorazepam or a diazepam. If you come to the risk factors for future epilepsy with febrile seizure are all except, here exception is there. You see all are risk factors for febrile seizure. That is, if they have a delayed developmental milestones, if they have a family history of epilepsy, or if it is a complex febrile seizure, that is, previously they used to call atypical febrile seizure. We don't use nowadays atypical febrile seizure. We use the word complex febrile seizure only. If they have complex febrile seizure, if they have family history of epilepsy or family history of seizure, or if there is a neurodevelopmental abnormality, definitely all these things are risk factors for the febrile seizure when compared to seizures occurring after 9 months. Therefore, that is one of the exception for your risk factors for the future epilepsies. Which statement is true regarding the febrile status epilepticus? How much percentage? Whether it accounts for 10% of febrile seizures, accounts for 20% of the febrile seizures, accounts for 25% of the all status epilepticus in young children, accounts for 40% of all status epilepticus. It is 25% of all status epilepticus we encountered is mainly a febrile status epilepticus. Quite common. Regarding the timing of febrile seizure during the febrile illness, when do most have their seizure? That is very, very important. Before the onset of the fever? No. On the first day of the illness, on the second day of the illness, on the third day of the illness? No specific day. Usually it is seen on the first day of the illness. Within 1 hour of the fever, they will have the seizure. That is on the first day of the illness. That is the correct answer. Which are the following febrile illness? I told you most common infection which is least likely to be associated with febrile seizure. Here you asked least likely. Least likely means I told upper respiratory tract infection is quite common. That is tonsillitis, otitis media, roseola, all those things when compared to gastroenteritis. Gastroenteritis is not the febrile illness that is associated with the febrile seizure. Okay. Regarding the genetic role in a febrile, I told you genetics play an important role. Which of the following statement is correct? Females have higher incidence than males. No, it is males have higher incidence. Autosomal recessive inheritance with high penetrance. No. Autosomal dominant inheritance with a low penetrance and locus heterogeneity. That is the most commonest genetic we are associated with the febrile seizure. Okay, a sibling in an affected family has 60% risk of having febrile seizure. That is not the thing. That is autosomal dominant inheritance with a low penetrance and local heterogeneity is the correct answer. Okay. Which of the following statement best describe the role of EEG in a febrile seizure? Predicts the recurrence risk of febrile seizure? No. Useful in both simple and complex types? No. A set point to diagnose febrile convulsions? No. Predicts the future risk of epilepsy? It may predict as a not recommended in febrile seizures. I told you it doesn't predict the future risk of epilepsy, and also it doesn't predict the recurrence risk of febrile seizures, and it is not at all useful in simple febrile seizure, and it is not a set point. It's always you should do a EEG in a febrile convulsion, is not the thing. Therefore, it is not recommended in febrile seizure, not routinely recommended in febrile seizure. Febrile seizure can evolve to or become associated with all of the following epilepsy syndromes, because febrile seizure can evolve into some other, like I told you, temporal lobe epilepsy due to mesial temporal sclerosis, severe myoclonic epilepsy of infancy, hemiconvulsive hemiplegia syndrome, whereas Lennox-Gastaut syndrome is a totally different entity. Whereas Dravet syndrome is the one which is associated with the febrile seizures. That is Lennox-Gastaut syndrome. Therefore, what are the percentage of children with simple febrile seizure developing epilepsy? The risk of epilepsy with simple febrile seizure is 1 to 2%. It is 1 to 2% with the simple febrile seizure. 3-year-old child with febrile seizure lasting for 5 minutes. It is GTCS type. Past episodes of 2 similar episodes in there. Child is hemodynamically stable. Parents are apprehensive. Appropriate management includes. Here, since the parents are very much apprehensive, it is always clobazam prophylaxis, intermittent prophylaxis is the best answer. No need to go for CT brain, no need to do lumbar puncture, no need to go for EEG. It is always clobazam prophylaxis is the best management in case of a child with a simple febrile seizure which is recurrent in nature. Therefore, it's a recurrent simple febrile seizure. Best treatment is a clobazam prophylaxis 0.5 to 1 mg per kg per day, twice or thrice a day for first 3 days of risk factors for recurrence of febrile seizure are all except we classify the risk factors as major and minor. In that age less than 1 year, yes, duration of fever more than 24 hours per seizure. No, usually the duration of fever less than 24 hours. Even with mild fever, seizures of 38 to 39 degrees Celsius, male gender, once again, the risk factor for recurrent seizure. Therefore, it is duration of more than 24 hours of seizure is not the answer because it is less than 24 hours. Usually, the febrile seizure should be seen. If you come to complex febrile seizure, differs from simple febrile seizure in the following aspects. Complex, it is focal in nature. Seizure lasting for more than 15 minutes. Recurs within 24 hours. Yes, occurring with low grade fever. It is not the one complex usually associated with high grade fever. High grade fever with a high temperature only. The complex febrile seizure is known. Correct regarding evaluation of first episode of simple febrile seizure in a 9-month-old child. What you can do first? First evaluation of simple febrile seizure. First episode. EEG should be done. It predict the future recurrence. No, EEG should not be done. Serum calcium and serum electrolytes are done to rule out dyselectrolytemia. If it is simple febrile seizure, you should not do any blood test. Lumbar puncture should be done in a child less than 12 months to rule out pyomeningitis. Especially if it is less than 6 months, we do. Only if it is less than 12 months, we do. If there is a if the vaccination is incomplete, especially if they are not taken the hib vaccine or a pneumococcal vaccine. MRI is better than CT in simple febrile seizure evaluation. It is once again it is all what center it is there and what availability is there, it depends. Here most appropriately you can take because there is still controversy exists between lumbar puncture. Some books say it is less than 12 months you have to do compulsorily. Some books say it is less than 12 months you have to do compulsorily. Because here we can take since lumbar puncture because MRI is not done in a simple febrile seizure evaluation. Therefore, your correct option will be your lumbar puncture should be done in a child with less than 12 months to rule out a pyogenic meningitis. Correct regarding management of a child with first episode of simple febrile seizure is what is the correct management? Intermittent anti-epileptic treatment is recommended instead of continuous anti-epileptic because it is the first episode. We don't advise. If seizure lasts more than 5 minutes, treatment with benzodiazepine is needed. Yes, parents at home can give diazepam rectal, intranasal, and buccal. Usually, we advise intranasal midazolam rather than the diazepam. Febrile seizure respond well to phenytoin and carbamazepine is very wrong. These two drugs are contraindicated in a febrile seizure. Therefore, the most appropriate answer here is if the seizure lasts for more than 5 minutes, we have to treat the patient with a benzodiazepine, either midazolam or lorazepam or a rectal diazepam. Okay. True about febrile convulsion is recurrent in nature, follows higher temperature, no spontaneous remission occur at 6 years onwards. Usually it doesn't occur at 6 year onwards. Therefore, here some MCQs may be having some controversial issues. Here recurrent in nature, usually febrile seizures are known for recurrent and usually it follows the higher temperature, no spontaneous remission occurs at 6 years onwards. Controversy between these two things. Okay. Therefore, they are telling sometimes they follow higher temperature. Usually there is a controversial question. Some questions may be they'll have a controversial issue. Very important one more is when do you label a seizure as epilepsy? Suppose seizure means one attack that is seized. Epilepsy means if the seizure occurs without any provocation, that is even one unprovoked seizure. When one unprovoked seizure will be called as a epilepsy. One unprovoked seizure will be called as a epilepsy. Which of the following abnormality is associated with generalized epilepsy and febrile seizure plus syndrome? It is the one which is associated with sodium channel mutation. I told you SCN1A. SCN1A, that is the one generalized epilepsy and febrile seizure plus syndrome is commonly associated. Which of the following abnormalities associate temporal lobe sclerosis? I told you temporal lobe epilepsy is the one which is associated with mesial temporal lobe sclerosis. That is most commonly associated with potassium channel mutations. It is most commonly associated with potassium channel mutations. And one more is, which of the following abnormalities associated with juvenile myoclonic epilepsy? The chloride channel mutations. The chloride channel mutations. If you come to the pathophysiology of any seizure, the precipitation of seizure, the, usually there are excitatory neurotransmitter and inhibitory neurotransmitter. The glutamate, GABA is our inhibitory neurotransmitter. Therefore, here what happens if it is increased glutamate and decreased GABA, the glutamate where it is increased and the GABA is decreased, then we think it is a one of the precipitating factor for the your seizure. There is increased glutamate, which is the excitatory transmitter, and decreased level of GABA, that is the inhibitory neurotransmitter. Then it leads to precipitation of seizures. Which is the most important differential diagnosis of first seizure? That is, whenever the first time, if we are seeing the seizure, we have to distinguish mainly from the one of the common encounter is called syncopes, where they'll have a transient loss of consciousness. You have to differentiate from the transient loss of consciousness. Nowadays, they are asking MCQs in a more of practice, where they'll give a clinical scenario, where based on the clinical scenario you have to decide, they'll give the MCQs. Suppose if you are a pediatrician working in a rural location and have just started a day shift, you are dispatched to a 3-year-old male pediatric patient shaking and not breathing. Immediately you think seizure. As you arrive at the house, a frantic father waves you down at the driveway. You follow the father into the house, and to your relief, your ears a child's cry, and walk in to see a mother holding a young boy wrapped in a cold towel. Upon your physical assessment, you find the patient is easily comforted, as GCS is 15, warm to touch with temperature of 38 degrees. All other observations within normal limit. Your partner obtains a brief history of the patient, and the parents are having trouble to recall events. The parents state patient woke up with a wet cough this morning. No other medical history, no allergies. It's a first time seizure. It's a first time seizure. Here, the URTI is the triggering factor for the seizure, that's the fever. Therefore, it's the first time. Therefore, it's the first simple febrile seizure. Okay. Therefore, what age bracket do febrile seizure fits? It is only between the 6 months to 6 years of age. What is the feature of complex febrile seizure? They are not less than 15 minutes. They can be more than 15 minutes in duration. A good outcome? No, because complex seizures with a focal onset, they have a poor outcome. Okay. And first line drug treatment for the patient still seizing is always your midazolam or lorazepam. You can give. As a part of your initial approach and assessment of your febrile patient, the most important is to ensure the patient has an adequate airway. That is very, very important. To ensure the patient has an adequate airway. And febrile seizure occur as a result of rapid rise in body temperature, definitely true. Even at low temperature also may rise, but it is always associated with a rapid rise in body temperature. Okay. Therefore, what mind doesn't know, eyes can't see. If you have theoretical aspects, if you know each and everything, in any format also they can prefer. Here also, with the what is the future epilepsy risk, the highest means it is neurodevelopmental abnormality, and what are the major factors and minor factors they can ask. All are the major factors except the some are minor factors. All are minor factors except which one is major. Like that, any question, if there is one risk factor, how much is the percentage of getting the epilepsy, the risk factor percentage, and any question can be found on the same topic. Okay. With this, I would like to conclude my talk regarding the febrile seizure with small description and some MCQs related to the your febrile seizures. Thank you.